All right, welcome back. In this final explainer, we're going to put it all together. We're moving from theory to practice. We've already established the what with frameworks like Bárány and titrate. Now we're going to build the how, a complete 10-minute workflow that pulls in red flags, medical history, and medication screening to create a really powerful diagnostic tool. And, right at the heart of this whole thing is your safety net. It's a really simple mnemonic called standing, and honestly, it is probably the most critical tool you have for spotting those life-threatening causes of dizziness. Getting this down is what separates a routine assessment from a potentially life-saving one. So here's what we're going to cover. First, we'll dive deep into that standing mnemonic for red flags. Then we'll look at how a patient's medical history and medications can really sharpen our diagnosis. And finally, we'll tie it all together into that practical 10-minute workflow and wrap everything up. Okay, so we've spent a good bit of time on the frameworks, right? Those are the essential building blocks. Now we're going to take those blocks and actually build the whole thing, the complete, actionable process you can use with every single patient who walks through your door. And let's just take a second to remember why this is so important. The whole point of this series is built on this one key idea. A structured history isn't just the warm-up act. It is the main event. It's the core diagnostic work that gets you to a diagnosis in most cases before you even start a physical exam. Okay, let's get to it. This is probably the most critical part of any vestibular assessment, spotting those red flags that mean you need to act and act now. This is where the standing mnemonic becomes your go-to checklist for finding those needles in the haystack. First up, S is for stroke features. So if your patient has vertigo and any of these neurological signs like double vision or slurred speech, you've got to immediately suspect a central acute vestibular syndrome. And your next move is crystal clear. Perform a HINTS exam and get them an urgent MRI with diffusion-weighted imaging to check for a stroke. Next, T stands for thunderclap headache. The thing to remember here is how sudden it is. We're talking about a severe headache that hits its peak intensity the very second it starts. This is a real medical emergency, and it needs an urgent CT or MRI to rule out a bleed in the back of the brain. Then we have A for severe ataxia. Look, if a patient suddenly can't walk without help because of major incoordination, that is a huge red flag. We're not talking about the little bit of unsteadiness you might see in BPPV. This is a profound loss of coordination that points strongly to a central cause. Okay, N is for Nystagmus, but specifically a central pattern. You really want to be on the lookout for Nystagmus that's purely vertical or that changes direction. But here's the real clinical pearl, it's the combination that matters. When you see this kind of Nystagmus or a skew deviation, but their head impulse test is normal, that is a massive pointer towards a central lesion. D stands for sudden deafness. When you get vertigo and a sudden hearing loss in one ear showing up together, you need to react immediately. The potential causes are pretty broad. Could be vascular, autoimmune, or viral. So the key action is to get an urgent audiogram and the right blood work to figure it out. The I is for an abnormal HINTS exam. And this one is so important because it's a bit counterintuitive. So if you get an abnormal test of skew, especially when the head impulse test comes back normal, that is not a good sign. It's not reassuring at all. In fact, that specific combo is a major red flag that strongly suggests a lesion in the brainstem. Our second N is for a new headache that comes along with the vertigo. Now, yeah, vestibular migraine is common, but context is everything here. If your patient's over 50 and has vascular risk factors like high blood pressure or diabetes, that combo should make you think posterior circulation stroke and think it seriously. And finally, G is for gait, a gait that is so bad the patient literally cannot stand or walk. This is kind of related to ataxia, but it's really about the total inability to even bear weight. This level of impairment just doesn't fit with your typical peripheral vertigo and points towards something much more significant, like a bilateral loss or a major central problem. So once you've screened for the really dangerous stuff with standing, we start to add another layer of detail, and that's context. We get this from the patient's past medical history and their current meds, and it helps us really narrow down what's going on. So really, the question you're asking yourself is this. What in this patient's background makes one diagnosis way more likely than another? It's all about clinical reasoning, right? You're adjusting your list of possibilities based on who is sitting in front of you. And you can see here just how much a patient's history directly guides what we do next. You see a history of migraine? Well, the chance of it being vestibular migraine just jumped up by 5 to 20 times. Got cardiovascular risk factors? You're going to have a much lower threshold for ordering imaging. Each one of these things, from autoimmune diseases to specific drug classes, points you down a certain path, whether that's ordering blood tests or simply checking your blood pressure lying down and standing up. Okay, so now we have all the pieces of the puzzle. We've got our frameworks, we've got our standing safety net, and we've got our context clues. Let's put it all together into one super efficient process, the 10-minute workflow that's going to become second nature for you. This whole workflow is like a diagnostic funnel. It's a logical sequence. We start broad, classifying the main symptom with a Bárány phenotype. Then, we use titrate to narrow things down by timing and triggers. After a quick screen for other symptoms, we run our critical standing safety check, and then we layer on that final context from their medical and medication history. See? Step by step. And what's great is that this whole structured process leads you to a really clear endpoint. After you figure out how much this is impacting their life, you're in a great position to make a confident syndromic diagnosis. And from that diagnosis, you know exactly what to do next, whether that's a specific exam, an investigation, or an immediate referral. And that, everyone, it brings us to the end, not just of this explainer, but of our whole series on the vestibular history. And this entire journey, it all comes back to one central, really powerful message. So if you remember one thing, let it be this. A systematic history, done in just about 10 minutes, can give you a solid diagnosis before you even lay a hand on the patient. The Bárány and titrate frameworks, they aren't just academic ideas. They are real-world, bedside tools that you can use every single day to navigate the complexity of a dizzy patient safely and effectively. So I'm going to leave you with a little food for thought, a question to think about in your own practice. If a really good, structured history can give you the diagnosis most of the time, what's left for the physical exam to actually do? Maybe its job isn't to find the diagnosis, but to confirm it. Thank you so much for sticking with us through this whole series. If you want to dive deeper into this topic or get more resources, please head over to our website. And hey, if you found this helpful, we'd really appreciate it if you'd subscribe and leave a rating. It really helps other clinicians find this material.